Welcome everybody for our live Q&A. I'd like to thank you for being part of this magnificent conference today. And thanks, of course, to all our speakers, some of which are here today. And again, thank you very much for taking the time on your Saturday to join us. So we have Dr. Del Rivero, who's here, Dr. Perez, Dr. Liao, and Dr. Khan. We also have Anna Greene from NETRF. So thanks again for all being here today. And what we are going to do is we're going to spend the next 35 to 40 minutes discussing some of the questions that either patients or care providers have sent us throughout the meeting. So I got a long list of questions, over 50. So thanks very much for sending all of these questions. Unfortunately, we can't answer all of them. We just don't have enough time. But I did pick up some of the questions that I thought were particularly relevant, and this will range from pretty sort of one-on-one basic net questions to more complicated and complex treatment sequencing questions. So let's dive right into this, and let's start with the first question. So the first question that one of our patients has asked is, what is the actual difference between grade, Ki-67, and stage? Perhaps we can have Dr. Del Rivero start with the first answer.
Yes, well, thank you so much for the invitation to be here today. So a stage refers to the extent of cancer spread. Usually that also includes where they're located, what is the size, as well as understand if they're spread in other places where also located. So that's usually a stage. It tells us in terms of if the patient is stage 1, if it's localized, to stage 4, which is called metastatic spread. Now, gray, on the other hand, describes more about how the cancers are looked under the microscope, and that can also indicate how aggressive they can be. And as you can hear earlier, between grade 1, grade 2, and grade 3, we know that grade 1 is also correlate with the Ki-67. And the Ki-67 is a method that the pathologists used in order to also understand differentiation and how the cells are able to divide under the microscope. And when I say grade 1 is based on the Ki-67 number, if it is less than 3%, we know it's grade 1, it's well differentiated. Grade 2 is between 3 and 20%, and grade 3 is greater than 20%. But I hope that explained the difference between grade and stage, unless anybody would like to add something. Thank you.
Absolutely. Thank you very much. Dr. Perez, how do you determine whether my neuroendocrine tumor is indolent or whether it is an aggressive tumor, and can that change over time?
Thanks for the question. So indolent mean the definition really is slow growth, and more aggressive would be faster growth. And when we talk about it, commonly is just the rate or the progression over time. So we're looking at scans and the change in dimension, change in the areas of the body that the tumor cells are spreading to. So if we're seeing something take years to grow in dimensions of measured in millimeters, we would consider that indolent. If we're seeing something grow, millimeters or centimeters over 3 to 6 months, we would consider that more aggressive in nature.
So one of our patients has asked also about grade creep, and perhaps Dr. Liao can take that question. What is grade creep? How common is it? And how do you detect it?
Yeah, good question. So grade creep is this phenomena where, maybe your tumor started off as a low-grade tumor, so, well differentiated grade 1, Ki-67 or 2%. And then over the course of treatment, the tumor kind of evolves. And I should say that, these tumors are made out of different clones of cells. And so these different clones evolve, and maybe one clone emerges throughout the course of treatment. So for example, let's say, if you have a pancreatic neuroendocrine tumor, at diagnosis it was grade 1, Ki-67 or 2%. And then after, let's say, PRT or CAPE-TEM, and 5 years later, we see the tumor is growing again, and then you do a repeat biopsy, and now it's a well-differentiated grade 3 tumor with a Ki-67 30%. So very different than the original diagnosis. And this is due to probably the evolution of the different clones of cells that make up a tumor. And as it gets exposed to different treatments, these clones kind of evolve. And we do see this quite a lot in our clinical practice, and also has been described in the literature as well.
Is it more common in one particular tumor type than another? And how do you realize that your tumor is undergoing great creep?
Yeah, good question. In my experience, I see it more in pancreatic neuroendocrine tumors than small bowel. I don't know if the other oncologists here have a different experience. And usually the telltale sign is if the tumor is behaving differently than before. So for example, if it used to be very slow growing and then you see this like one particular tumor, say in the liver, double in size within, 3 months, then that's a sign that there's something different about that tumor that it's doing compared to before.
Dr. Perez, any other insight in great creep?
I think sometimes though, with grade creep, we're sometimes fortunate to see that change when we look at, we perform a second biopsy. But I think also probably more commonly, we see the change on imaging and clinically, but we do the biopsy and we don't always see that change. And I think it's sometimes difficult for patients to kind of put together when we're saying that the Ki-67 is the same as their disease was 3 or 4 years ago, but the disease itself is acting very differently.
Okay, now I'll ask you a follow-up question that the patients did not answer, but what you've told me, if I would be a layman or laywoman, would sound like, it sounds like certain therapies can induce great creep. So should we avoid these therapies, or is this just part of the game? And is there any particular sequencing of therapy that is more likely to induce great creep? So should we give the chemo maybe before PRT or PRT after chemo, or does it matter? Has this been studied, Dr. Del Rivero?
Yeah, it's an excellent question, and it's a research question as well. We're trying to understand whether there is any factors that had make the tumor from being less aggressive to more aggressive. What I can say is a lot of the therapies, different therapies tend to also disorganize some of the cells in a way as having their killing effect. And thus we would say that that's when the tumors may acquire more mutations. As we get older as well, and it's part of life in a way, we do acquire mutations over time because there is external factors that can also cause that. And as you know, Dr. Keutgen, you also study a little bit of epigenetics and understand those factors as well. What we know is that there are certain therapies that can't increase this burden of mutations. In that situation, can sometimes disorganize the cells in a way that there may be a clone of cells that they may be more aggressive compared to others. There is also an idea that sometimes when a patient may have treatment with PRT, and maybe I would like to know the thoughts of Dr. Perez or even Dr. Keutgen as well, since you do research in that aspect as well Dr. Liao, is that sometimes, when there is a type of treatment that can't has an effect on the bone marrow function, and then you have another therapy like temozolomide, which is an alkylating agent that can also has an effect as well on the bone marrow function and have a further increase the risk. So sometimes we see an increase of NDS, but at the same time, we have seen that the clonality of cells, so how the cells that are able to differentiate, may also change. That said, it still is a research question. I think we're still trying to understand that aspect. And when you say about sequencing, we also said that there is not like one size fits all for neuroendocrine tumors. The treatment is personalized from patient to patient, understanding also the clinical characteristics of the patients, understanding what is the volume of tumors, or how much tumors is seen in the body, whether it's in the liver or not in the liver, whether it expresses somatostatin receptor or not. I think there is a lot of clinical characteristics that help us guide the specific therapies, or the therapies that we think in terms of sequencing for patients. But now we are understanding as well as the many side effects that we over time we have learned. And in that situation, we also make the recommendation and explanations of what we see in the different therapies.
No, I agree. I think it's a really important question, and we have a lot more to learn, right? The next question is an interesting one, which goes a little bit into this. It's a treatment sequencing question, since we're talking about this. And perhaps like Dr. Perez can help us answer this question. Are there molecular markers or tumor profiling results that could influence treatment choices? And I would add to that a second question: should everybody that has a neuroendocrine tumor that is metastasized undergo genetic sequencing or at least molecular profiling if there are certain markers that would change our treatment choices?
Yeah, I think that's a great question. I think what's unique to neuroendocrine tumors is the fact that traditionally it had been considered somewhat molecularly bland when we looked at it. And so, unlike some other cancers where there have been targeted therapies based on a genetic profile, neuroendocrine tumors have not always had that. But I think as more novel therapies arise and as the technologies have become more accessible in profiling the tumor DNA, I think it's just so much more important to consider having tumors be profiled because of the newer targeted therapies that are available. And I would say that pancreatic neuroendocrine tumors tend to be the one amongst the neuroendocrine tumors that seem to share some of the mutations that we can see in kind of the unrelated pancreatic cancers, like the pancreatic adenocarcinoma, where we may see things like KRAS mutations, we may see things like BRAF mutations. And I think that's where we have in oncology in general have come up with impressive targeted therapies that patients can safely receive if their tumors have that profile. But I would say we're still kind of, compared to other more common cancers, probably not where we need to be in regards to targets and genetic profiles for the tumors themselves.
If I can summarize your answer, useful in certain situation, probably not commonly, but certainly more research needed, and hopefully we'll get one day where we have real reliable biomarkers, right? Can we agree on that?
I talked instead of just saying
No, that's perfect. I just wanted to summarize because this is exactly how I see this too, to be honest with you. I mean, certainly all on this call have done different research about different biomarkers and prediction to certain therapies. We have researched how, for example, in peanuts, MEN1 mutation, could potentially increase progression-free survival after PRT, but it doesn't necessarily mean that anybody with a MEN1 mutation should first get PRT before they get like CAPE-10, right? So these are all questions that I think we still need to research. I'm very happy to see that Dr. Chandrasekharan has joined. So, Dr. Del Rivero, you had a comment.
Yeah, I was just wondering if I could add just a small comment because
Sure, of course.
Perez said, in terms of, when and the indication of doing molecular testing. But sometimes when I hear some of the patients saying, well, I want my tumor to be tested because I wanted to know whether I have something that may affect my children's, right? So, and I think it's important to differentiate, when they do genetic testing, because that's kind of within the umbrella of genetic testings, that there is testing that is done in the tumor, which that's called, we call molecular testing, a molecular panel, which is only done in the tumor. And there is also germline testing, which is done, and it's usually a saliva or a blood test. And that's kind of like tells me whether there is any risk of a familial predisposition syndrome. If it's positive, it will appear at every cell in the body compared to the somatic, which is only in the tumor. Now, when I say germline testing, if there is a question about what is the risk that I may have a familial syndrome related to neuroendocrine tumors, as I mentioned earlier, is usually 10%. But the ones that we have seen in more association with the familial syndromes is the pancreas neuroendocrine tumors. But usually, in order for us to determine there may be a familial syndrome, there is other clinical manifestations that help us suspect that. So the neuroendocrine tumor by itself, it doesn't mean that that will be associated with a germline or familial syndrome.
Very important to
Can I add
make sure that everybody
something?
understands. Yes, of course.
Yeah, so there can
Anna.
also be a role for testing for neuroendocrine carcinomas. So just wanted to kind of put a pin in that. And then for unknown primaries. So if you, profile the metastasis, it might give you some indication of where the unknown primary is.
That's also a great point. For example, somebody comes to you with metastatic disease, you can't see anything in terms of primary tumor, but you sequence the tumor, it shows you a MEN1 and a DAX mutation. that's going to be a pancreatic neuroendocrine tumor, which again may influence your treatment, because if first line or second line is going to be chemotherapy like CAP10, we know that that tends to work better in PNETs than in small bowel nets, right? So that's one of the example where this could certainly play an important role for treatment choice. Thank you very much. Very important point. Let's go to Dr. Khan so he doesn't fall asleep on the call here. So there was a liver-directed question specifically about insights about when to use histotripsy as the right treatment for a liver metastasis. So the histotripsy is something that we've talked about a lot, I think, over the past few years. Can you tell us, to you in your mind, what is the ideal candidate for liver histotripsy?
Yeah, I would say that one, it's a very new technology, and we're still figuring out the appropriate clinical setting, the appropriate ethical setting to use it. Certainly, it's one that shows promise, but treat every potential tumor that can be visualized on imaging. There's a lot of questions that go into it. So the initial evaluation to see if the lesion is even amenable to histotripsy is to visualize it under ultrasound. Most of the tumors that we can treat with the curative intent are usually 3 centimeters or less. And so those are sort of the primary considerations. Whether or not that's a single lesion that's been progressing, some of the trials have done like 1 to 3 lesions that are less than 3 centimeters. So multiple lesions that can be treated with curative intent, those are ones that I would consider as ideal candidates. Certainly, there's some wiggle room in terms of can we combine treatments with histotripsy and blend embolization. That's sort of what I've been looking into with some of the patients that Xavier sent over to me. But whether or not those yield significant results in terms of treating one area and other areas, the tumor is decreasing, those are all things that are under research consideration.
Is location important? So, for example, I'm assuming you have to see the liver tumor on ultrasound, right? So
Yes.
tumors, for example, that are at the dome, at the very superior part of the liver, right under the rib cage, is that generally an issue?
Yeah, typically ones that are located up at the dome are difficult because there's adjacent or superimposed lung, and histotripsy requires sound waves traveling through a medium. They don't travel through air. And of course, your lung is filled with lots of air. And so those are not ideal locations for histotripsy. Usually the ideal location is the anterior lower part of the liver. Some of the central lesions are better suited for histotripsy. Comparing it to ablation, the closer they are to central structures, there is sort of a benefit there because thermal ablation or microwaving a tumor that's close to arteries or veins or the bile ducts can be a little intimidating, and then histotripsy offers the potential since it doesn't injure those structures. So those are all things under consideration for histotripsy.
Great. Thank you very much. Let's move a little bit into the PRT category. So it's a broad question, but I think it's an important one, which is how do you know when to initiate PRT? How much tumor growth do you need to have? How much spread do you need to have? What if there is spread and growth in multiple locations, but the tumors are very small? So what in your mind is an ideal candidate for PRT, and should we start it early or should we wait later in the treatment course?
The one easy answer to the question is who is a candidate for PRT, since the peptide receptor therapy is hinging upon the presence of these octreotide receptors. The first answer is only patients who have adequate octreotide receptor expression on the tumor surface are the candidates to be considered. And that's important when you look at certain subtypes like lung neuroendocrine tumor patients, or even within rarely you see even small bowel neuroendocrine tumor or pancreatic neuroendocrine tumors not have enough octreotide receptors, or the higher grade tumors. In interpreting the results of the PET-CT, I think that's important because a lot of times we see these PET-CTs reported as positive, but when you actually have it reviewed in a high volume neuroendocrine tumor center, the degree of octreotide receptor expression is not very high. So key thing for the patients to recognize, if the doctor says it's positive, it could mean still nothing until it's truly positive, which means the tumor cells are lighting up as good as the spleen or better than the background liver. So that's key thing. So if you don't have receptors, not a candidate for PRT. The second part of the question that is asking about when is a good time, I think that's a question that is not just relevant to PRT, it's in general a question that's relevant to pretty much any therapy option. We have patients where we just say, hey, let's just wait and watch, you're doing fine, you don't have symptoms, and then the tumor is slowly growing or every scan shows something, and then the question comes up, when do we start treatment? So that is an answer, I would say, not restricted to PRRT, but in general. I think we do have some data, definitely clinical trials like NETR2 specifically, which is a trial that looked at PRRT upfront in specific subset of patients. So those that have high grade, the proliferation rate, we call as Ki67 greater than 10%, and looking at it upfront. So no doubt PRRT is an effective treatment, maybe even more effective in pancreatic neuroendocrine tumors or some of the higher grade with more response rates. But this time we don't have data that the overall survival has improved by doing it earlier. So I don't think these trials answer the question to me about everybody needs it upfront just because you met the criteria of high-grade tumor. Now, if a patient is very symptomatic with high volume, and we are thinking about an option that would give them a good chance of shrinkage and improvement of symptoms or volume of disease, certainly this is a good option to consider. Now, speaking of patients who have a very slow, indolent type of growth, gradually growing every single time, I think it's a very hard decision to make as to when do you treat and jump to the next treatment. I think this is really where we spend most of our time. I wish we had like metrics. I'm curious to hear about all our other colleagues on the call as to are there decision factors that help. To me, what I practically use in clinic is still rely upon the sense of growth or the pace of the growth of the tumor. You know, if there is growth like of 1 centimeter over 2 years in a grade 1 small bowel neuroendocrine tumor, that would still necessarily not push me to say, let's just do PRRT. So if it is a consistent growth in the sense there is definitely like more than 1 or 2 scans consistently showing a trend of increase, or the increase in such a way that I'm worried about if it continues to increase, there's going to be trouble. There's going to be some kind of a symptom. Those would be the factors I consider when recommending a treatment or a PRRT. I mean, that's not just PRRT, like I said, any type of treatment. And the second factor is, of course, the patient's preference. I think it's not the second factor, probably the primary factor as well, right? There are patients who would be hesitant to go forward with treatment in that situation, in that particular year of their life. They could have other things. And honestly, if there's no urgency, I would say, well, maybe not this year. That's fine. It's not going to change your treatment in the overall longer run. So wait it out. Let's see what happens to the tumor. Let's do it next year if it's a school holiday, summer holiday for you or something like that. So there is no good answer and no biomarker, no amount of a certain tumor percentage growth. A lot of the clinical trials do use the index of growth over the past 1 year or 6 months by a certain percentage, what we refer to as RECIST criteria. So sometimes I do use that in clinical practice as well.
Great, thank you for this very comprehensive answer. This is fantastic. Dr. Liao, I'll follow up on this with you. So, because I have done many clinics with you, and many times I see you take decisions on when to use PRT. So, 2 questions. Does the location of the tumor matter, or the distribution, I should say, throughout the whole body, right? So let's say you have somebody that progressed on long-acting octreotide, right? But the majority of this disease is, let's say, in the bone versus in the abdomen or the liver. Does that matter in your treatment choice, number one? And then what about volume in general? Are you somebody that thinks that the larger the volume, or particularly if you have a very large tumor, in addition to many other tumors, that tumor should be maybe targeted separately in addition to PRT with something else? How do you see those 2 factors?
These are great questions. So location definitely matters, or the pattern of spread of the disease. That's yet another factor, in addition to everything that Dr. Chandrasekharan mentioned, that factors into our decision of whether or not to pull the trigger for PRT. So if you have disease that's all over the body, bones, lymph nodes, liver, etc., then it may make sense to choose a treatment that will treat the entire body at the same time. But on the other hand, let's say if only the liver tumors are growing, or most of the disease is in the liver, then there are other options. There are liver-directed therapy, and we're also a center that does liver debulking, and so we sometimes do surgery. So I think the location of the disease, the pattern of spread, and the pattern of growth, what's growing, I think those are all important considerations for us to decide whether it's PRT or whether it's local regional therapy. And then the second question is also a good one. So the volume of disease. So if someone has a lot of liver metastases versus someone who have small tumors in the liver, And, there's data from the NETRF study originally showing that people whose liver tumors are smaller actually benefit better from the PRRT. If you think about it, PRRT is kind of one size fit all. Everyone gets the same dose. And, there are new ways of trying to kind of improve upon standard PRRT. One of them is called dosimetry. So like calculating the dose based on the distribution of the tumor and the uptake and things like that. And so I do think that the volume does play a role as well. And the NETRF study already showed us that the patients who have smaller liver tumors do better with PRRT versus people who have bigger tumors.
Thank you very much. Okay, let's go to more diagnostic question, but related to PRTs to a certain type. And, this is a question I think every clinician gets quite often after patients have read the reports of the PET scan and show up in clinic. And the question is, what is more important on the PET scan? Is it growth or is it avidity? I think that's an excellent question because many patients, I think, get scared when they see, oh, my SUV max went from 24 to 43. What does that actually mean? Dr. Perez.
Oh, I was going to put my finger on my nose as like a not it. Just kidding. So I think what I explain to patients is that we have two different PET scans that are available to us, and one has been around for a much longer period of time. So when we talk about something lighting up in the SUV, that patients will see numbers in parentheses next to a description of a finding. The older PET scan that's used more commonly for other types of cancers, there has been a tremendous amount of work correlating the changes in that value with the activity of the tumor, where for neuroendocrine and with the PET dotatate scans, I think we're still very much trying to figure out how to correlate that number with the activity. And then the size, when we're looking at PET scans, becomes even a bit more tricky. And I definitely, this is where patients get a little bit more confused because they'll say, I just had a CAT scan or an MRI and my tumor was this size, and now the PET scan says it's that size. And what I try to remind patients is, one, it truly could be representing that there's a change or a growth, but it also is that the functionality of the PET scan is one in which it's kind of like a sparkler on the end of, attaching to a protein or, something anchoring it into the tumor cell. So you're going to get, if you think of a sparkler, since it was just the July 4th holiday, you have this really small stick, but you have a very big spray of color. And that's really the problem when it comes to measuring the tumors with the PET scan. So always take the size with a grain of salt and just know that we are all working on trying to figure out what that number means and how relevant it is for your care and for your treatment options.
That's a great answer. I completely agree with you. You call it a sparkler, I call it the light bulb effect, the halo, where sometimes, something just appears bigger as you get closer to it because of the light halo, but it doesn't necessarily mean that the size is actually like that. Does anybody on this call look at SUV max and change in SUV max? So let's say we have a patient that has had a gallium dotatate PET a year ago, has another one now. The disease distribution looks exactly the same. The size, like you mentioned, is hard to measure, but comparing side by side looks pretty much the same. But the tumors look much more intense, so they have more SUV max values or higher values. Does that matter at all to any one of you, or would you say it really doesn't at this point?
Do we look at it? I think yes, out of curiosity to learn more, as Dr. Perez mentioned. Do we ever use that to necessarily decide on things? Not less likely. There are some studies that have looked at a certain level of threshold of SUV, not the change from time, but rather the actual cutoff of if your SUV max. There are some literature studies that say that a 16 number and over may indicate more receptors or those that are candidates for PRRT. Again, there's a lot, that's not clear in that kind of these studies. So for that reason, I do look at the SUV, but not necessarily look at the change in the SUV from a treatment decision perspective.
Thank you for that. So an interesting question that is a more general question as well, but I think a really important question. And I'm sure all of us being a multidisciplinary high volume center, we get asked this question. When should palliative care or integrative oncology teams be involved in my care? I think that is a really important question. Dr. Del Rivero.
Thank you so much. Very important questions. And usually in terms of somebody seeing a palliative care physician, I usually recommend from the very beginning on the journey. Sometimes that is a scary word for a lot of patients because they feel that when it's palliative is the end of their disease course, end of life. But that's not necessarily the case. So usually what I tell the patients is that palliative care is important because it helps patients to then live their best life possible while also understanding the journey of the disease and also have appropriate measurements and also appropriate support in order to understand and live with the disease as well. But I will say I will definitely want to, ask Dr. Chandrikha since that's one of her area of expertise.
Yes, if I can ask another question for you, Dr. Chandrasekharan. What can palliative care offer, or what does palliative care discuss that perhaps the medical oncology team does not?
I think that second part is also a very interesting question. And I think it's a little bit different from other cancers in terms of, specifically neuroendocrine or any other cancer that has a more indolent course. There's lots of base literature about early integration of palliative care, for example, in lung cancer, maybe even improving survival. So Dr. Del Rivero summed it up very nicely. It's about living your best life, right? Enabling that. So the first thing is to remove the stigma of palliative care being like a negative connotation. Think of it as a supportive care. Anything that helps you live with a cancer, with a life-limiting illness, which definitely neuroendocrine tumor is. And that support for different patients can come from different ways, whether it's a symptom management question or what do we call anticipatory grief in the setting of cancer that may be life-limiting or life prognosis, or for some patients, even some diarrhea management, though we do have some traditional tools of diarrhea management, which is a common symptom, fatigue, which is a number one symptom reported by neuroendocrine tumor patients with neuroendocrine tumor, sometimes shortness of breath. So a whole bunch of symptom management, interventional with medications or non-interventional, supportive care therapy, psychiatric counseling or a therapist. It's a whole bunch of services that they can offer. And again, every patient has different needs. And so it's kind of, I think many times the medical oncologist or surgical oncologist or whoever is your primary netologist is kind of your person, and they have to definitely include palliative care depending on the need of the patient at some point in this journey. What do they offer that a medical oncologist does not offer? I don't think we should single out medical oncologists thinking that everybody is a palliative care necessarily comfortable with it, right? It's any oncologist or any surgeon or any specialist, let's say. Why would it still be helpful to be seeing a palliative care team dedicated to that versus just folding it into your regular oncology care? Now, some of this may not be literature supported, but there are issues that the patients may hesitate to discuss with an oncology team or surgical team that maybe this is a different platform for them to voice those concerns. For example, there are some studies in palliative care that have shown that patients who's felt, if I talked about this, my doctor is not going to recommend a therapy for me because I'm mentioning the symptom. They're going to worry I can't handle this treatment, right? So they may hold back on that. So just an example of how a separate dedicated team is still helpful. And in the practicality, I'm palliative care trained and I'm oncologist. I try to wear two hats in one clinic and we can't. We have a certain amount of time and we can spend a certain amount of time. I want to focus on the disease at sometimes. I want to focus on the symptom. So sometimes having this dedicated team, especially in patients who could potentially benefit with high symptom burden or any sphere, physical, psychological, would be helpful. They are just a wonderful team to have on your team when you need them. So I don't know if that answered the question generically, but the timing of when to introduce, is there like any literature to say at diagnosis, midpoint, later point? I think that's really no literature.
Thank you very much. Very comprehensive answer, and I think a very important question. Now, you mentioned diarrhea. Nobody wants to talk about diarrhea, but it's a nice segue to the next question that I have for Dr. Liao, which is how do somatostatin analogs control symptoms from small bowel neuroendocrine tumors such as diarrhea when that is also considered a side effect of the drug? How do you know the difference, Dr. Liao?
That's a great question. So there's often many different reasons for diarrhea, and sometimes we really have to tease it out from the patient's history to figure out what's the predominant reason. So, carcinoid syndrome, serotonin, that can cause diarrhea. So that's the hormone that's secreted by the tumor. So myostatin analog in itself can cause diarrhea as a side effect. It can also cause pancreatic insufficiency, which can present with not just diarrhea, but bloating, flatulence, foul-smelling stools, greasy stools, oily stools, and things like that. A lot of our patients have had surgery, so having had their terminal ileum removed, they get into issues like bile acid reabsorption. And then typically the history is, I wasn't having diarrhea before surgery, and suddenly after surgery, I'm having like nonstop diarrhea. And that's treated with like things like cholestyramine. And then some patients have lots of small bowel removed and they get some kind of malabsorption diarrhea. So there's often a lot of different reasons, and sometimes there's many reasons going on at the same time. And so really have to take a careful history. So for example, if the patient's saying the 4th week after the lanreotide shot, the diarrhea is coming back, the flushing is coming back, well, maybe then primarily then it's the issue of the serotonin of the carcinoid syndrome. And so I think taking a very careful history is key to differentiate the different causes.
Thank you very much. Going back into the PRT category, Dr. Perez, what is the best alternative to PRT if I have renal insufficiency? So can those patients still get PRT, or is this an absolute no?
I'd say it's there's no absolute in any of the treatment options that we have. And I think for patients who have a diagnosis of renal insufficiency, working with a nephrologist to really characterize the chronicity of it, the stability of their kidney function, optimizing if chronic, addressing any acute issues or medications that may alter their kidneys' tolerance of it. I think what we have found, though, with longer term follow up and more patients receiving PRRT, that the radiation impact on the kidneys is real, and we need to consider it. And I think as we're looking at new radioligand therapies, it's still on the forefront of our concerns for toxicity. But I think with the protein fluids that we give immediately after the PRRT, we're actually seeing that the protective benefits of that has really limited the concerns that we had initially.
Would you adjust BRT dose in some patients? So give them, let's say, half a dose if their renal function is below a certain threshold. Is that something to practice, or
It
everybody
has
gets the same
been.
dose regardless?
No, I think that has been the benefit of practicing it during a time that this is becoming more and more available, and there's more and more patients that are receiving it, that we can come at this in the same way that we're coming to the table with medicine or chemotherapy based options. It's really what's going on with the patient, what's their blood counts doing, what are the kidney function, all of that during the time that they're receiving PRRT from the get-go, adjust and readjust as they continue on treatment. So I think that we're getting there. And I think with dosimetry, that's also going to influence it. So I think that there's not going to be a set exclusion necessarily as we fine tune how much we give it, and really allow it to be more patient or individual based.
Perfect. Thank you very much. One question that is close to my heart, because I think it's a controversial question and finally relates to surgery a little bit, is a question one of our patients asked, which is how important is it to locate and remove the primary tumor with all these treatment options that are available? Who wants to take a jab at this?
I'm volunteering you.
Okay, well, I thank you very much. So I would say it depends. So there are certainly studies that are all retrospective and probably all biased, and that I've written myself in part, that says that removing of the primary tumor might improve overall survival. I think it's a very controversial topic. And I would say that there are certain situations when, in my mind, it's a slam dunk. So if a patient has a small bowel neuroendocrine tumor and is symptomatic from the primary tumor, such as cramping or difficulty eating, weight loss related to that, I think that patient needs to have the primary tumor removed, even if there's too much metastatic disease to do something surgically. I think this is something that is really going to help in the long term. On the other hand, when we talk about pancreatic neuroendocrine tumors, they're rarely symptomatic. I mean, some can obviously, depending on where they are located, if it's in the head of the pancreas, cause biliary obstruction, for example, but that generally gets treated very well with stents nowadays. When they're in the body or the tail of the pancreas, they rarely cause any, unless they're very large and and like compress the stomach. But I think when it comes to removal of primary tumor, it comes really down to quality of life is number one. Is this tumor symptomatic or not? And if it is, and it can be reasonably removed without delaying therapy too long, systemic therapy, I think that's something that we should consider. I'm sure you've all seen and heard of patients that have had, for example, peritoneal disease or even a lot of mesenteric disease or multiple small bowel primary tumor that receive PRT and get into small bowel blockages. That's a potential side effect of PRT. So again, I think carefully studying what and how this could be helpful for our patients is certainly something that we still need to do. And I would say it makes sense in certain situations. Sometimes we can't find the primary tumor, right? I'm sure we all have patients where we cannot find the primary tumor. And does it matter? Well, again, we talked about this with Anna before. It can sometimes matter for treatment sequencing perspective to try to figure out where the primary tumor is. But even if it tells you it's a PNET, on molecular testing, you may never see a PNET. So that certainly plays a role as well. And I've also had patients that had limited liver disease. I've debulked, and the primary tumor even 5 years later has never shown up. So, these are all possible scenarios. And again, I think what you probably all learned throughout this conference, and I think we can all agree on that, is that every patient is unique. And yes, we have great treatment options and choices. And yes, we have done tremendous progress over the last 10 years, and we will continue to do that in terms of treatment. But the truth is every patient is different. Every tumor will behave differently. And so this is why it's so important to continue the research, number one, and to also be seen in a multidisciplinary center where there's a tumor board and where clinicians really have the experience to try to choose what's the best therapy for you. And sometimes there isn't the best therapy, and it's really up to the patients as well. So this is it. So I got to talk the last 3 minutes. Thank you, Kim, for letting me do this. And thank you to all of you for spending your Saturday afternoon with us. I really, really appreciate you taking the time off to answer these questions. I would like to commend all of you for tremendous conference. I'll also like to thank Josh, who is on this call here. He's helped with gathering all the questions and posting them. And of course, I'd like to thank NETRF for, again, organizing a fantastic conference. And we hope to see you next year. So thank you very much to everybody.
Great. Thank
Take
you.
care.
Thank you.
Thank you for attending Know Your Nets and spending this time with us. We hope you have increased your knowledge of neuroendocrine cancer. I want to recognize Dr. Xavier Keutgen, my co-chair, for his leadership. We are grateful to all our speakers who shared their time and expertise, and to our thrivers who offered perspectives and hope. This has been a NETRF team effort, with special thanks to Jessica Thomas, Jennifer Long, and Anna Greene for the tremendous work to bring you Know Your Nets. Rich Tamayo is our video producer, and Josh Mailman, a member of our NETRF board, helped to manage the Q&A. Know Your Nets is possible because of support from our co-sponsor, University of Chicago Medicine, and all our sponsors, Exelixis, Curium, Crinetics, ITM, and RayzeBio. Above all, thanks to you, the neuroendocrine cancer community. If you missed any parts of this program or want to watch it again, we will be posting the conference video on our YouTube channel. You'll also be receiving a survey in the next few days. We love feedback, so let us know what you learned and what we should include in future programs. If this program has been helpful to you, please support NETRF. We depend on community support to advance research so people with neuroendocrine cancer will have more treatment options. You can visit our website to learn more about our Breakthroughs Today, Cures Tomorrow campaign. That's netrf.org. Remember, NETRF is here for you. You are not alone.